to the Coding Corner Medical Coding Education channel. My name is Rebecca Broyles, and I want to talk about Ambulatory Surgery Center coding basics, the foundations, rules, examples, and best practices. Today we're going to talk through the fundamentals of ASC coding, how it differs from physician and hospital outpatient coding, some common pitfalls, and practical examples you can use in daily work. What is an ASC? ASC, or ambulatory surgery centers, are designed for procedures that don't require overnight stays. Coding must align with Medicare's ASC list, which determines what is payable in this setting. Now, the Medicare's ASC list is a type of payment system. It's ASCPS. It covers surgical procedures performed in freestanding or hospital-operated ambulatory surgery service centers. It was established to provide a payment system that is primarily linked to the hospital outpatient prospective payment system, or the OPPS. The ASCPS sets payments for procedures using a set of relative weights, a conversion factor, and adjustments for geographic differences in input prices. Beneficiaries are responsible for the Part B deductible and 20% of the ASC payment rate. The system is designed to incentivize ASCs to consider the cost of the package of services used to treat a patient during a surgical procedure. Now, the ASCs still use the CPT, HCPCS, and ICD-10-CM codes for the procedures and diagnoses. Physicians bill CPT codes for their professional work. The ambulatory surgery centers bill CPT or HCPCS codes for the facility's resources, such as staff, equipment, or supplies. Understanding the distinction prevents duplicate billing. There's no E&M services billed by the ASCs. Supplies and implants may be separately payable, and the modifiers differ. Some key coding sources to help you distinguish these codes are the CPT Professional Edition, the HCPCS Level 2 book, the ICD-10-CM Official Guidelines, the Medicare ASC Payment List, the NCCI Policy Manual with edits, and the CMS ASC Payment System Addendum AA. ASC payment is not based on the RVUs. Instead, each CPT code maps to an ASC payment group with a fixed rate. Understanding what's packaged versus separately payable is essential. Modifiers 73 and 74 are unique to facility building. Use 73 when the procedure is discontinued before anesthesia, and use 74 after anesthesia or after the procedure has begun if the service is discontinued. ASC documentation must support both the CPT code and any modifiers. Missing laterality is one of the most frequent audit findings. You need to document the procedures performed, the laterality, the approach and the technique, the devices or implants used if applicable, the start and stop times for any discontinued procedures, and any complications if applicable. Some common ASC coding pitfalls to watch for are billing non-covered procedures, missing or incorrect modifiers, unbundling services, incorrect implant billing, and using physician coding rules instead of the ASC rules. ASCs often struggle with bundling rules and payer-specific implant policies, so regular audits help catch these issues early. Some best practice recommendations: maintain updated payer policies. Use NCCI edits for every claim. Conduct internal audits. Educate surgeons on documentation needs and track denials to identify trends. ASCs with strong coding education and audit programs consistently outperform others in reimbursement accuracy. Some case examples. Here we have cataract surgery. Patient undergoes phacoemulsification with IOL placement. 66984 for cataract removal with IOL. And then the V2632 HCPCS code for posterior chamber IOL if the payer allows separate payment. Medicare bundles most supplies, but some commercial payers allow separate implant billing. You always have to check per payer policy. Another is colonoscopy. Screening colonoscopy converted to diagnostic with polypectomy using snare. You would use the CPT code 45385, colonoscopy with snare polypectomy, the diagnosis code of Z12.11, screening converted to diagnostic, with the modifier PT. You want to show Medicare that the screening was converted to diagnostic. This ensures correct cost-sharing rules for Medicare beneficiaries. An orthopedic ASC example: a knee arthroscopy with partial medial meniscectomy and chondroplasty. 29881 meniscectomy is primary, and 29877 is for chondroplasty, but this is bundled per the NCCI edit. You would see as you looked at the NCCI edit that it bundled the chondroplasty into the meniscectomy when performed in the same compartment. This is another common ASC denial area. Pain management: lumbar epidural steroid injection under fluoroscopy. 62323, lumbar ESI with imaging. Imaging guidance is included, so there would be no separate billing for that. ASC coding can be challenging, but if you have the resources that are required, it does make it more manageable and more compliant. Thank you for watching. Please visit us at www.thecodingcornermce.com. Thank you.